Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field and the classroom each month. Episodes of this podcast can get you 1 full hour of CE through our partner, emt-ce.com, so head over there for more information. I'm your host, Steve Williams, and with me is Dan and Holly. Guys,
hello,
welcome
Steve.
back.
Hi.
Good to have you.
We're
Good
back.
to have you as well.
Yeah. And real quick, we got to introduce our guest because he's actually in studio with us today. Dan, do you want to introduce
Absolutely.
him?
Honored to introduce Dr. Ramsey Selbak.
Yeah.
Thanks for having me, guys.
Yeah.
Thanks for
We're
being here.
excited to have you, man. We're going to do some case review.
Yeah.
Is the plan. And before we get going, I had a little surprise I thought was kind of cool to fill you guys in on. So I was on shift last night, and I get a phone call from my buddy Dave, who is over in Central Oregon. And he's like, hey, I wanted to share something with you. And kind of a random phone call. Like, Dave and I are buddies, but like to get a phone call from him instead of a text is kind of different, you know. So I go, yeah, man, what's up? He's like, well, I'm working with this guy who just started. They're both at an academy over there. Dave just lateraled over to a department over there. And he's like, I got this guy that came here from Nebraska. He's working big city department. And he listened to your guys' podcast and said, yeah, I need to move to Oregon.
Whoa.
And so he up and moved his
Wow.
entire life.
Wow.
Got a job working in Central Oregon because
That's
he heard our
awesome.
podcast and thought it would be a cool place to work.
Jeez, that's cool.
Oregon
Yeah.
is a cool place to work for.
It is.
It is.
For paramedics.
Yeah.
Yeah.
And we need medics, so
We need medics.
you guys can all come out here. We'd love it. But I thought that was pretty cool. I
Yeah.
didn't think we were having that big of an impact on people, but
Yeah.
apparently,
It feels like a lot of
I
responsibility.
know. I feel like, oh, shoot.
All right, I'm going to take this
All the
serious
native
now.
Oregonians are going to be pissed at us.
Yeah. Yeah. We got to keep the,
Like an Oregon commercial,
yeah.
you know?
I don't know. Like, Visit Oregon, is that a thing?
Sure.
It is now.
Yeah. Maybe I got to buy that domain name. All right. Well, Doc, I was thinking what we would do is we would talk about you have the case, so
Yeah.
the three of us
Yeah.
with kind of a non-doctor mentality are going to kind of pepper you with questions and be like, just kind of seeing if we can get our bearings around it, and then we'll just kind of go from there. But it
Yeah.
sounds like there's some really good lessons for EMS on this
I
one.
think so.
'cause-
Yeah. We'll kind of approach it pre-hospital, hospital, and then kind of outcomes and pitfalls and things that, thankfully didn't come up. It could come up, and
Sweet.
I'd be interested in your guys' take as well, because we're not there pre-hospital, so I'm also
Right.
interested to see
Yeah.
how you guys deal with these cases, and we can all learn.
Yeah.
So we'll kind of work through it and kind of go stepwise. And
Okay.
does that sound reasonable?
Sounds
Yeah.
good.
Yeah.
And I know you've been on the show before, but just for other people, you are a physician in a level 1 trauma center in the ER.
Yes.
That's important.
There,
Yep.
and then I moonlight in a small critical access hospital as well. But
See it all.
Yeah.
Yep.
And real quick, give us the status of healthcare right now
ooh,
in the state.
it's rough.
I just saw a LinkedIn notification from OHSU, which is another level 1 trauma center up in the Portland area, and they were saying, you know what? Let me find this real quick. I was stunned at the language they used, which throughout COVID I never heard them use in their announcements on.
I would say even right now compared to COVID it's maybe worse.
Yeah,
Yeah.
that's
Just,
kind of what I was gathering.
just the bed. I don't know. Bed wise, it feels anecdotally it feels like there's less space.
Mm-hmm.
You know.
A lot
Here's-
of people are leaving healthcare, too.
Yeah.
So there was an op-ed in the Oregonian, which for those of us who don't know anything about Oregon, it's the major newspaper and online publication for news in the state. And Dana Bronner and Ben Hoffman wrote an op-ed for the Oregonian, and it was titled, "As Sick Kids Fill ICU Beds, Oregonians Must Pull Together Again." And they took out a quote from that in their LinkedIn notification post, and it says, "We want to be clear that this public health emergency constitutes the greatest threat to children's health in our state that we have seen in the last 30 years. If this sounds dire to you, it's because it is."
Wow.
Yeah, Dana Brainer's awesome.
Yeah.
He's like the head of the PICU at OHSU. I've worked with him during residency.
Yeah.
Awesome guy, awesome doc.
Mm-hmm.
Yeah, no, I think especially in pediatrics right
Yeah.
now, the state of the hospitals is scary.
Yeah.
Just lack of beds, lack of resources. You know, PICUs are full, floors are full, waiting rooms are full.
Yeah.
Mm-hmm.
You know,
We're having upwards of 2.5 to 3 hour waits for a bed. So we're sitting with patients in hallways before we can drop them
No.
off. And they're using EMS as like essentially
The
faux
eyes.
nurses and
Yeah.
medical assistants to kind of help out.
Hmm.
And it's a really weird time because like we're having people that are stuck at the hospital and our city is blowing up with more calls
Yeah.
and we can't release people to,
Mm-hmm.
you know, we can't drop the patients off. And so we're triaging people all the time now. Before it used to be like, oh yeah, we triage that guy because it
Right.
was so minor. And that was kind of rare. And now it's like daily. We're doing it
Mhm.
at least once or twice.
And just to
Um,
note, your hospital is not a small hospital.
No, it's a level 2.
Yeah.
Yeah. We're the regional medical center in the area.
I think that's the case in a lot of places.
yeah, it's tough right now for sure.
Mm-hmm.
We're supposed to be trying to bring people to Oregon with this podcast.
Right. Yeah, sure. We'll get it figured out.
Yeah, we'll get it figured out. I think it's everywhere though.
I think
You
it is
know,
too.
People
Yeah.
are, yeah. I mean, that being said, it's, you know, people are still coming together, and
Mhm.
you know, it's tough, but
Yep.
people are still doing a good job. I think especially on the pediatric side,
Mm-hmm.
you know, they're doing a good job, like flexing spaces, changing criteria, so that now kids that used to go to the PICU can go to the floor, and
Mm-hmm.
you know they're doing what they can.
Yeah.
So
Well, keep doing what we're doing.
Yeah.
But okay, should we move into this case?
Let's do it.
Okay.
Good.
sure.
So why don't we just start? You go with wherever you think we need to know, and we'll ask questions.
Yeah, I mean,
along
I
the
was
way.
thinking I would go with, hey, I'm in your guys' shoes. I get this is the call. This is what you guys, you know, based on what I heard from EMS, this is what they saw when they walked in the door kind of situation. And then we can like kind of ask questions and work our way through what happened pre-hospital, hospital, et cetera.
Yeah.
Does that sound
Yeah.
reasonable?
That sounds
Sounds
great.
Yeah. Okay.
Yep.
So you guys are working, you're on shift. You get a call. It's a mid-60s-year-old female in respiratory distress.
Okay.
Essentially is
Is
what
she
you know.
at like a care home or is she
She's at her home. She's
Okay.
at her home with family, pretty supportive family.
Do you know what the status of the house is? Is it
I think pretty like
just
well,
normal?
yeah, normal.
Okay.
Yeah,
Okay.
fairly normal folks. You know, actually providing pretty good history.
Okay.
Yeah.
Cool.
How they present when EMS arrived?
So what EMS says is they walked in, they found this lady tripoding, very tachypnic, in severe, what they described as pretty severe respiratory distress.
So as you walk in, you're differentiating between sick, not sick. So
Yeah.
this person's sick.
This person's sick.
Okay.
Yeah, they came code white. Code 3 at a manual. Anything that comes in that's
Code
like,
3 is
yeah,
code white.
Yeah, code white's like, hey, they're going to be a respiratory case, generally cardiac
Okay.
arrest, things like that are code
Okay.
whites. But they came in code 3.
Okay.
Gotcha.
So they were pretty worried about her.
What was the transport time?
I think it was pretty quick, like maybe under half an hour.
Okay.
Like 20 minutes.
Okay.
And they didn't stay and play too long.
All right.
Yeah.
So initial SATs, vital signs.
Yeah, so they walk in, she's tripoding, initial sats, she's a little hypertensive. I think she was in like the 180s systolic. She's a little tachycardic, probably like low 100s. Her sats were in the low 80s
Ooh.
when they got in.
What about
Okay.
lung sounds?
Lung sounds, they thought she was wheezy.
Okay.
So they thought she was wheezy. Also, just a little more history they got there. No COPD diagnosis, but a smoker,
Okay.
active smoker, smokes 1.5 packs a day for quite a while.
Any other medical history?
Yeah, quite a lot. So what they knew coming into at least what I gathered from them was smoking history, also on dialysis.
Okay.
Had gotten dialysis the day before, so hadn't missed any dialysis that they knew of.
Okay.
And did they pull off a normal amount the day before? Was it anything abnormal?
So day before, great question. So this lady had a lot of stuff going on. So new onset AFib. So she'd been having some issues getting through her runs of dialysis. So she was like a Tuesday, Thursday, Saturday gal. Got dialyzed the day before, but got a half run. The run before that also got a half run. So at least 2 runs of dialysis where she got a half run of dialysis because she was going into AFib with RVR. So they
man.
couldn't get
Oh,
her
wow.
through
Was that
dialysis.
on the EKG when they found her?
No, she was not in AFib with R. She was actually normal sinus.
Okay.
Maybe a little tacky, if anything, but not in AFib.
So you said wheezy, so no pulmonary edema?
So report I got, this is pre-hospital, so report I got before I'd even laid hands on the patient was she sounded wheezy. They gave her some Decadron. They put her on oxygen. I think she was on 10 liters when she came in. Her SATs had improved. Didn't give her any breathing treatments en route.
Did they say why?
They didn't say why.
Okay.
Yeah.
I mean, I'm sorry. Was there fluid? Were we thinking there's fluid in the lung sounds?
So you want to know what I heard?
Yeah. What'd you hear?
So I get her. She's satting better, still kind of in the low 90s, still tachypnic but not tripoding. She's on 10 liters, doesn't use oxygen at home.
Okay.
Blood pressure's about the same, 180s, 190s. She's like maybe borderline tachycardic afebrile. I listen to her lungs. She is a little wheezy. She's one of those cases where you're like, she sounds wheezy, she sounds wet.
Yeah.
You know, she was a lot of crackles, diminished breath sounds at the bases, a little wheezy throughout. But I felt like more wet, more volume lung than wheezy on my exam.
Gotcha.
Any like peripheral edema?
Yes, she had probably like 2-3 plus peripheral edema, which she said was relatively new. Yeah,
Okay.
a little JVD.
Yeah.
And how long had it been going on again?
Pretty rapid.
Pretty rapid.
Yeah, so it's fairly sudden onset of I can't breathe per report.
Okay.
So with that, I mean, as a paramedic, I would go to
CHF protocol.
I go to BiPAP and
right. Well, BiPAP with that, sympathetic crashing acute pulmonary edema escape, that new thing that's been coined. That's what, per my protocol, I would have went down, which is IV nitro.
Yeah.
That's kind of where I would have went because of
Yeah,
high blood
I mean,
pressure, tachycardic.
Our CHF protocol is BiPAP. It's a breathing treatment through the BiPAP. It's monitoring end tidals, blood pressures, IVs, and then it's a nitro drip if you have any sort of a transport time.
Right.
and afebrile, so you're not thinking pneumonia
Right.
in that case.
Yeah.
Or any cough. Anything
No
like
cough.
That, no?
No real like URI symptoms.
Yeah. Like exertional dyspnea or anything like that?
She was, I mean,
At this point,
yeah.
but
Right.
Prior to
Prior
that.
to
I mean, a little bit, yeah. Yeah. Since her new AFib, she'd definitely been more short of breath, it sounds like, over the last few weeks. Yeah. So that's kind of where we're at with her. I think I was maybe working with a resident that day, and we had this same discussion.
yeah.
So, I mean,
Especially with missing dialysis. Now
Yeah.
you're thinking of some electrolyte disturbances
Right.
or maybe fluid overloaded.
Yeah,
Yeah.
what were her labs?
yeah, so we get some labs back. Her electrolytes are okay from like a, renal dialysis standpoint.
Potassium.
Potassium was fine. It was in the 4s. Her EKG was like sinus tach, but nothing, nothing major on the EKG. Her BNP was like greater than 4,500. Her gas looked relatively okay. She was retaining a little bit, but not like a terrible COPD.
Yeah. Does she have a history of heart failure?
No,
No. Okay.
no.
Could you explain just for our listeners BNP?
Yeah, pro-BNP is a lab that we get that basically measures the amount of stretch that's going on in the heart, and that gives us an indication if there's some degree of heart failure.
Gotcha.
It's not like an end-all lab, but I would say like that, greater than 4,500.
Part of the picture, yeah.
Part of the picture.
So greater than 40?
Greater than 4,500 on our lab is like kind of as high as it gets, essentially.
Okay.
Yeah. So, there are things that for BNP that can throw it off. People that are obese can, you could be in florid heart failure and your BNP is normal, right? So it's a part of the picture.
Gotcha.
But if it's like through the roof with that picture, it definitely kind of points you more towards that.
Okay.
So, I mean, some other things, I did an ultrasound on her, point of care ultrasound, B lines everywhere. So do you guys know?
Nope.
Do you guys use B line?
Nope.
Like do ultrasound? So pulmonary ultrasound, you can use a cardiac probe, look at their lungs, and B lines are essentially indicating that there's a lot of pulmonary edema. So it's kind of the way it scatters the ultrasound sound going through the lungs is it looks kind of like a flashlight, like looking through your lungs.
And she had
a lot of pulmonary edema on ultrasound, so lots
Gotcha.
of B lines.
Okay.
So kind of pushing us more towards a pulmonary edema picture.
Okay.
Yeah.
So this is where I get a little intrigued because we, if we hear someone is having a dialysis issue and they have that history, I mean, it's hard for me not to zero in on that as
Me
at
too.
least 50% of the problem every single time.
Yeah.
And so if I hear that, I'm always nervous to really do much of anything, primarily because I don't want to screw things up, because I know that it can be a massive complicating factor for patients.
Yeah.
So
her heart looked okay relatively.
Okay.
So the other thing, you know, some of these dialysis patients get these big effusions. And they can be in like tamponade. She didn't have any evidence of tamponade. Definitely looked like she had pulmonary edema. The other important thing is she doesn't make urine.
Right.
So, you know, a lot of dialysis patients still make some urine, and those patients, if they're really volume belong like this, you can slam them with Lasix and get some of the fluid off. So it makes no urine. So that's another important part of the picture.
And what's in the pre-hospital toolbox, then we're thinking Lasix or nitro, of course.
Right.
But so that's out.
yeah.
Nitro, BiPAP.
Yep.
I mean, that's pretty much it, right?
Yeah.
As far as helping with fluid overload.
And you know, the reason this case I think is interesting is I think I was working with a resident that day, and all these things came up in discussion, right? And your option, you're exactly right. So you want to get fluid off this person's lungs, BiPAP, nitro, emergent dialysis if you need to dialyze them. But I listened to her heart, and she's got a just whopping systolic ejection murmur. Like, sounds like she has severe aortic stenosis, right?
Jeez.
So I don't know if you guys have any.
I have heart and lung sounds I can play. Let me see if I can bring up a heart tone here.
Now, was her aortic stenosis something she knew about?
She had not really. I mean, she knew about it, but not to the degree that she would be able to say, like, hey, I have severe aortic stenosis.
Yeah.
She's
I've never
like,
had anyone be like, oh, I've got high blood pressure and I've got this.
Right.
And then later you find out, oh,
Right.
aortic stenosis, like, what? Isn't that something you would tell people?
Right. And, you know, she's like,
it's
oh,
like-
yeah, I have a heart murmur. That's
Yeah.
kind of what because I listened to her heart, and I said, you've got a pretty severe murmur. She's like, oh, yeah, I have a heart murmur. And that was kind of the end. Like, she's like, I know I have a heart murmur.
Okay.
Any clues that we could have on the pre-hospital side if they don't have a good history?
I think the murmur.
The sound.
Let
The
me
sound, yes.
let me play a normal heart tone.
Yeah.
I've got that on here, and then I'll play a aortic stenosis tone. 1 second. Here's normal. So that's a normal S1, S2. Okay. And then here is aortic stenosis.
Oh, wow.
Sounds abrasive.
Yeah. And I think that, you know, oftentimes it's a little more high pitched than that. And, you know, the classic teaching is it'll radiate up into the carotid so you can hear it up in the neck, things like that. So I don't know how often you guys are listening for that.
I
mean, I'll be
Guilty.
honest now. I'm going to be, anytime I'm thinking about BiPAP, I'm going to be listening to heart tones.
Yeah.
It's, you know, so that,
I would say as a paramedic, I probably never did, but as a nurse, definitely I did.
yeah.
Yeah, I'm definitely not there.
Yeah.
Right. And I don't know if, like, so in your guys' protocols, let's say they tell you they have aortic stenosis. Like, what would that change in
It's
your
not even captured.
No,
pre-hospital
nothing
protocol for
at all.
nothing?
Yeah, there really is nothing pre-hospital.
Yeah.
But this is significant because
It is.
like
Yeah.
if we don't change, let's walk down what happens if we
Exactly.
give everything we would normally give for a CHF patient on this call.
Right. It's usually, you know, a calcification of the valve itself, right? So the valve is now you're pushing blood through a fixed valve,
Right.
right? So you're pushing blood through like a pinhole, you know, for just simplification, right?
Okay.
So your ability to get dynamic blood flow through that valve is kind of gone, right? So, you know, the teaching is that if somebody has severe aortic stenosis, they become preload dependent, meaning anything that you give them that drops their preload now drops their ability to have forward flow of blood flow.
Because they're trying to push it through such a small
Yeah, because it's a fixed valve.
yeah.
Right. So if you know, and I've seen this clinically, and at least the teaching in the hospital is, you know, you do not give these patients nitro, for example. Right. You give somebody with severe aortic stenosis nitro, and nitro is a venodilator, drops their preload, and they code.
So like, I mean, you were saying this lady had a systolic of like 180.
Yeah.
And so, I mean, shoot, I'm still thinking at 180, I got room. I got plenty of room.
Yeah, me too.
And you don't necessarily.
Yeah, because of this, you know, they're so preload dependent. You know, and like, sure, maybe they would tolerate it, but I've seen cases where, you know, people give nitro to a person with bad aortic stenosis, and they code.
Yeah.
You know, so that, you know, this is part of the reason this patient was so challenging, and, you know, thankfully she didn't get nitro.
Right.
So anything that drops your preload, especially IV nitro, right? And nowadays people talk about giving IV nitro, which is, it works great.
Yeah.
But if you've got aortic stenosis and you've got this, you know, preload dependence, and now you dump a lot of IV nitro, tank their preload, they've got no more forward flow, they go into cardiac arrest.
Jeez.
Wow.
And that would have been our only choice in the field because Lasix wouldn't have worked.
Right.
Right. So you would have gone
Right.
straight to nitro
Yeah.
Right.
had they done anything.
Right. Or BiPAP.
Yeah. Right.
Yeah. And, you know, even BiPAP is, you know, anytime you get any sort of positive pressure ventilation, right, whether it's a tube or BiPAP, that also decreases your preload.
Yeah.
Mm-hmm.
Right. So it's something, BiPAP's great because you can always take it off,
Mm-hmm.
right, if their pressures don't tolerate it, or you can turn down your settings. So BiPAP, I think, is reasonable, but it's also something that drops your preload for these people. Aortic stenosis patients can be really severe ones can be pretty challenging to manage. And she was challenging because she doesn't make urine. She's got terrible pulmonary edema. She needs dialysis, and she's got aortic stenosis, and she probably has COPD.
Yeah.
Right.
Right. So
Just
it's
to
like
add a little.
yeah. So there's
So
kind of
walk us through, what did you end up doing for her?
we ended up, and the other thing is, if you give them a bunch of breathing treatments, right? What do people who give them a bunch of albuterol? What happens to them?
Their heart rate increases.
Crazy.
Hypertensive, anxiety, tachycardia.
Yeah, they become
palpitations.
if you become tachycardic, what does that, you know, decrease?
The preload.
Or your filling time.
Right.
Right. So it decreases your filling
Right.
time pretty dramatically. So even that, like if you got a patient like this too tachycardic, that could also get you into trouble too.
So their lack of treatment actually helped.
Yeah. So in this case, you know, they actually didn't do much, which was great.
Yeah.
Yeah.
And I
Luckily,
don't-
she improved with the non-rebreather
Yeah.
because then they
She
would
im-
have been forced to do something.
Yeah, she improved. Her vitals were relatively okay. I mean, our plan was if she gets worse, we'll put her on BiPAP and keep her super close eye on her. I admitted her to the ICU to get dialysis is what she needed more than anything, and to kind of sort out why she wasn't tolerating dialysis. You know, sort of obviously beyond the scope of pre-hospital and beyond the scope of the ER as well.
Right.
But interesting case because it would have been really easy to really mess it up.
Yeah.
So let's say you put her on BiPAP.
Yeah.
Do you have a cutoff point, like her pressure goes down to what before you take her off of it?
You know, I wouldn't have put, like, clinically, I wouldn't have put her on BiPAP just because, like you said,
was doing better.
she was doing better.
Okay, let's say she did not improve.
Yeah, then I would have probably put her on BiPAP with RT at the bedside so that we could titrate settings.
Okay.
And hopefully, you know, like you said, her pressures were high, so
Yeah.
probably would have done okay. And if she didn't, you know, if her pressure started to tank or if she started to clinically look worse, then I would bring her settings down. And then I would, you know, at that point, you'd say, hey, she needs emergent dialysis, right? You'd be
Gotcha.
calling in nephrology. And she's going to the ICU no matter what.
Right.
But, yeah.
Wow. Do you know how she turned out?
Yeah, I think she got dialyzed the next day because she was pretty stable overnight and she did fine. Yeah.
She's
But-
lucky.
Yeah, but, you know, it's interesting because this comes up a lot with, like I had a resident that day who wanted to give nitro too, and it's a good learning point. But I wanted to talk to you guys about it because I wasn't sure how much this comes in play
Yeah.
in the pre-hospital setting. And have you guys
Zero.
ever seen, you know, bad outcomes
Oh,
from
yeah.
AS and
From giving nitro?
Yeah,
Yeah.
from aortic
absolutely. And then
stenosis,
you're
yeah.
like, what's going on? And
I
is
never
it,
put
is
the
it,
two together.
Is
No,
it because
never.
their respiratory state is just getting so bad now we
Uh-huh.
need to intubate, you know?
yeah. So this is something you guys see in the
Yeah.
field, but it's not something that's, hey, we need to kind of keep this on our radar.
Nope.
Yeah.
No one bit.
So
Yeah.
if someone, like, let's say you have someone with aortic stenosis and they're
Yeah.
not in a crisis,
Right.
are there classic signs? Like if someone has CHF, you can kind of tell, like, they have the peripheral edema. There's certain things we're looking for to
Yeah.
say, oh, that's probably going to fit into this category.
Right. Yeah. I mean, the sort of the classic signs aside from the murmur, right? And I will say murmurs in general are not going to necessarily it's very rare that I listen to a murmur and it like changes dramatically what I'm doing for the
Yeah.
patient, right? Because people have a lot of benign murmurs. But in this case, if somebody's got a very classic aortic stenosis murmur and is in this sort of clinical picture, it's definitely something that I think about, right? So it kind of gets you back to the physical exam a little bit, which I think we've all sort of moved away from, right?
Yeah.
So I think there is still some value in it, in getting a good heart exam and a good lung exam before you start doing interventions. And we're so used to all these interventions
Right.
that are really truly like critical care interventions, but we don't really think about them like that anymore, because it's like you're doing it every day, I'm doing it every day. But it's good to like sometimes step back and be like, oh, this is an intervention that actually could cause harm, right? But the other classic, exercise intolerance.
Okay.
Syncope is a big one. If you have an elderly patient that's exercising and they syncopize and they've got this murmur, things to think about, right? So, and then you can get heart failure signs from remodeling of your LV from the stenosis,
Right.
So it's it can be a little cloudy, but if you hear that murmur, I think it's something to think about.
So if it's so preload dependent, are you going to see, like, do they classically have hypertension, or is it
Not
just
necessarily
kind of vary?
Yeah, it varies. And a lot of people walk around with aortic stenosis, especially in the elderly population, and it's a big spectrum of disease, right? But it's these patients that you're going to be giving medications to or doing interventions to that you have to think about that, right?
So everyone start listening to heart sounds,
Yeah.
so you know what they all sound like.
So it's not necessarily something that is contraindicative of giving someone BiPAP.
No.
I mean, it has to be someone who's in, is it
kind
an
of an
acute
extremis,
phase
sort of
of
an extremis.
aortic stenosis?
Yeah, more severe cases. But BiPAP less so. The nitro, I think, is really the one you'd get in trouble with.
Yeah.
BiPAP's great because it's something you can turn on and turn off.
When I'm giving nitro, I have one thing on my brain usually, and it's how much space do I have with this patient?
Right.
So if I'm at 180, I'm not worried about nitro.
Right.
Because I'm only I have my blinders on. I'm only looking at blood pressure.
Me too. 100%.
And it's okay. Even if this makes them worse, I'm not expecting it to drop their pressure 100 plus points.
Right.
Maybe 40 at the most.
Yeah.
And then that would be a big sign like, oh, shoot, they were really sensitive to that. I'm going to hold off, or I'm going to go to a drip because the drip is so much smaller compared to a tablet or a spray. But
Ours is bolus.
you do an IV bolus of
Yeah.
nitro? How
Yeah.
much? We do anywhere. I mean, we think we start at 10 mics a minute.
That's what it is, 10 mics a minute.
Yeah. And then
And
we
it's
can
just
go up to
10
100.
mics. It's just a bolus.
Okay.
And they do even, I have to look it up too, but the high dose IV nitro is like, I always look it up anytime I give it.
Yeah.
But it's a lot more than that.
Oh, it says
Steve,
here
do you have any other murmur sounds that we
Yeah.
can compare it to?
Yeah.
1,000 to 2,000
Yeah.
micrograms.
Yeah. It's a lot.
And that's the bolus, right?
Yes.
And I can't remember what our protocol said.
Yeah.
I've been out of that for a while.
And for, acute flash pulmonary edema, like, works great.
Right.
Yeah.
I do have some more heart tones on here.
So because we're not experts at heart murmurs,
Yeah.
and probably people aren't very good at listening to them all the time, or maybe you only hear one heart murmur a month.
Right.
It's hard to differentiate between which ones are
Yeah.
which.
Yeah.
So if they are in extremis and they have some of these classic signs and we hear a murmur,
Yeah.
is that a time to pause and think, will nitro?
I think that if you hear a, harsh, high pitch, systolic ejection murmur, kind of classically at the, right upper sternal border, kind of over where you hear the aortic valve, right? I think it's something to think about at minimum.
Yeah.
Yeah.
And I mean, always follow your local protocols.
Yeah.
We're not, insinuating anything in lieu of that, but it's definitely something to think about. And if you were to see this in the field, I would say call your medical control and say,
Yeah.
this is what I
Absolutely.
got. And
Yeah.
what do you
Yeah.
think?
Right.
Because it's not necessarily written or captured in our protocols. So
Yeah.
we want to do something a little outside the box because we heard this could be a thing.
Yeah.
And I think it all depends on your, like you said earlier, like what was the transport time?
Yeah.
Right. Like
Totally.
if you're 5 minutes from the hospital, maybe don't stay and play and,
Right.
Yeah.
mess around.
Yeah.
We've all heard your story about that.
Dane's got a story for everything.
Okay.
So can you
why
say
you
that?
shouldn't do
Can you
that.
say that location again for the heart sound? The right.
Right upper sternal border. and then it classically radiates up into the neck. So if you listen,
so
over
you're
there,
pointing to basically just right of the manubrium.
yeah.
Yeah.
So classically when you listen to hearts, right upper sternal border, left upper sternal border, left lower sternal border, and then kind of left chest, right? So the way I always remembered it was the mnemonic in med school was Arnold Palmer, the man. So it was like aortic valve, tricuspid valve, pulmonic valve, Arnold Palmer, tricuspid valve, mitral valve.
Wow.
Right.
Arnold
That's
Palmer.
hard to follow on a
is.
podcast, but like if you're listening to murmurs, that's kind of where they'll be coming from. Like that's like one of the mnemonics. There's many
You want to hear the
mnemonics.
mnemonic we learned in paramedic school?
Yeah.
It was TPMA, like going through the different valves. Toilet paper my ass.
Yeah.
That works.
Yeah.
That's how we learned
Yeah,
it.
it worked.
Not for listening, but
Yeah.
just for learning.
Yeah. How blood flows through the heart and everything.
A little different.
Usually those ones stick.
Yeah, right.
Yeah. No pun intended.
No pun intended, yeah.
So
Two-ply.
we've got a couple different sounds here we can listen to. Is there anything specific you think we should maybe review that would be more important than others?
I'd like to hear the difference between the different murmurs, just to hear what that
Yeah.
real.
Can you start with normal again?
Yeah, I'll start with normal and then let me play. I have what's coded as an innocent physiologic murmur.
Mhm.
Yeah. And then Dan, here is normal again.
So it's the flow thing that's the murmur. Where
Yeah,
to
it's
me,
like
I visualize flow.
Yeah, it's like a turbulent.
Yeah.
Mm-hmm.
What you're picking at, what you're hearing is turbulence of the blood flow, and or some of the other valve. You can sometimes hear the like clicks of valves opening at the wrong time, et cetera. But
And is that because it's flowing through an area that's narrower?
yeah,
Yeah.
and there's some physics.
Yeah.
There's some Laplace, I think, was the right. I don't know. We can look
Wow.
it up, but
No, that sounds really, really smart. I'll trust you on that.
You
Just
say
gonna start making up
turbulent,
words.
Yeah.
turbulent flow.
you say Navage?
Yes.
Okay. What else you want to listen to? That was. I have a holosystolic murmur.
Okay.
Okay.
Here it is. That sounds bad.
What is that again?
Is that a defect?
Yeah. it's a-
Ventricular septal defect?
Yeah.
Is that what that one is?
Holosystolic murmur. Yep.
Yeah, that's what that sounds like. So I mean, you
That
can
sounds
hear.
like blood's barely getting through.
Well, I think what you're hearing there is blood going across the V. Is it a VSD?
It doesn't say.
Yeah. And so, I mean, the important thing I think when you're listening to murmurs is what's the location. And I wouldn't overthink this too much.
Yeah.
It's just, I think if you have a patient in extremis who you're going to be giving interventions like BiPAP, nitro, breathing treatments, Lasix, things that can alter their physiology, and they have a murmur, right? It's just like keep it in the back of your mind.
Right.
Just
Yeah.
like if you have an inferior STEMI, you don't give them nitro,
Right.
right?
Yeah.
Like it's
Right.
keep that in the back of your mind. I wouldn't say like if you hear a murmur, I think, I mean, I don't know. We listen to murmurs a lot. I don't know how much you guys listen to murmurs, but
We just don't.
even if you,
Yeah.
but it's not like I said, it's very rare that I'm listening to a murmur and being like, oh, I'm changing what I'm doing at the bedside because of this murmur. But I will say, if you hear like a high pitch systolic murmur that sounds like aortic stenosis, you can, Google it, listen to what that sounds like in a patient that's sick that you're going to be giving these types of interventions to. It's a good thing to think about.
Yeah.
I think that's awesome because I feel like we did learn heart sounds, of course, in paramedic school
Right.
and nursing school and things, but they're not hugely applicable to emergencies,
Right.
which is
No.
what everybody in the field is concerned about. And so I think it's just that knowledge that goes by the wayside until something like this comes up.
Right.
Yeah.
That's very applicable. And
Yeah.
so
It's one of the
now
first
I
things
bet
that we
you're going to
just-
be listening to lung sounds or heart sounds all the time.
Yeah. It's one of the first things that people write off because I'm in the back of an ambulance. I can't hear it anyways.
Right.
Yeah.
And it's like, well, if you can listen on scene for even just a little bit to,
Yep.
capture what you might be able to glean from it would be important.
Yeah. And there's a couple, like acute mitral regurg is another one that people get sick from. Really
We
sick.
have, I have mitral valve prolapse.
Okay.
And then the other ones are varying types of splits.
Yeah, I think the splits can be pretty subtle,
Yeah.
and sometimes those can be physiologic too.
What's a split?
It's like an S split, S1 or S2.
Oh, okay.
Yeah. So you're basically hearing the valves closing at a little different time instead of together.
Uh-huh.
if that
Oh,
makes
got
sense.
it.
Yeah.
Okay.
Let me, here's a mitral valve prolapse.
I feel like those seem to be more of a common one that you would
Yeah.
hear.
Yeah, and to me, the other important thing is trying to differentiate like systolic versus a diastolic murmur. Diastolic murmurs tend to be worse, or the teaching is that, classically. But I would focus on
And that's the second sound.
correct.
Yeah.
Yeah. So kind of after S1, S2,
Mm-hmm.
right? I think that, I don't know, the thing I would want if I were talking to medics about this stuff is to just be aware of the preload dependence in aortic stenosis. Because I think you could get a little lost in the weeds on murmurs,
Yeah.
truthfully.
Totally.
And they're really subtle. And when you're in the back of an ambulance trying to listen to a murmur, I think that's very challenging.
Yeah.
Or if
Yeah.
you're on a helicopter,
Yeah.
or
Right. That
I've
becomes possible.
done ride-alongs with you guys, and it is very challenging. Like, a ton of respect for medics that they're able to hear anything.
Yeah.
kidding.
In the back of a rig.
Yeah.
So it gets. I mean, I don't want to get too lost in the weeds on, hey, you should be able to pick up X, Y, or Z murmur, because I think it's pretty challenging. But I think these types of patients that we're resuscitating, if you hear that, I think your idea of, hey, maybe call in and say, hey, this is what I've got.
Yeah.
I hear this really harsh murmur. And some people know. Some people say, like, I have bad aortic stenosis, right?
Yeah.
I'm waiting to get a TAVR or aortic valve replacement of some sort, right?
So if they tell you that, hold off on the Lasix, the nitro.
I would.
Okay.
Yeah, in a
Yeah.
pre-hospital setting, I would.
Okay.
Yeah. Or again, if you had a long transport time, I would call in.
Yeah.
Yeah. Run it by your online medical control.
Yeah.
See what they think.
Man.
Yeah, I think that's great. And the things that we've learned is if you hear a murmur, just think twice. And then the location of where the murmur you would hear that aortic stenosis.
Yeah.
So I was thinking, when you hear long sounds, it's like sometimes they resonate.
Uh-huh.
Does it happen too with, like, if you're listening over like the right quadrant for a murmur and
Yeah,
then
you
you
can-
listen like under the armpit?
Oh, definitely. Yeah. If somebody has a really harsh, aortic
Yeah.
stenotic murmur, yes, you can
Yeah.
hear
You
it
can hear it.
throughout the kind of the
Yeah.
precordium, but
Mhm.
but that
And like
is-
that high pitched sound.
Yeah, you can definitely hear. It tends to be loudest, I would say, at that location,
Mhm.
but you can definitely hear it
Yeah.
throughout your heart exam.
Paramedics love this stuff. Like they would live for the one call where they were
Yeah.
like, "Sorry, doc, they have aortic stenosis,
Right.
and we didn't do it." Like everyone's gonna be on their A game now, trying to find that one person.
Yeah.
So I'm looking at the Mayo Clinic's website, and they have the long list of symptoms of aortic valve stenosis. Curious your take on this, doc. Obviously, heart murmur, heard through a stethoscope, chest pain,
Mm-hmm.
angina or tightness with activity.
Yep.
Feeling faint or dizzy or fainting with activity. Shortness of breath, especially with activity.
And that it makes sense physiologically, right? So when you're pumping blood through a fixed valve,
Mm-hmm.
right, you're not able to augment your cardiac output.
Mm-hmm.
So when people are active, when you and I are active, our heart beats faster, and our stroke volume goes up, and we pump more blood through to meet our metabolic demands, right? And these people with activity that have this stenotic valve and they have a fixed amount of blood that can go through can't meet those metabolic demands, so they faint, or they get
Yep.
chest pain, right? And that's kind of like sort of makes sense.
Yeah.
Yeah, absolutely. It says fatigue, again, all that, especially during times of increased activity, rapid fluttering heartbeat, and then it talks about specifically in children, not eating enough and not gaining enough weight.
Mm.
Symptoms of aortic stenosis in kids. So there's obviously a genetic component to this if kids are getting it, right?
Yeah, I mean, I'd say the vast majority, that would be the rare case, right? It's
Really?
Yeah, I would say it's atypical in kids. It's mostly elderly patients who get calcific valves. Right?
Is that typically from lifestyle choices?
Lifestyle choices, part of the aging process, part
Gotcha.
of the, our American body habitus. You can get bicuspid aortic valves is another common reason that they get stenotic. But I'm not a cardiologist, but my guess is the most common is kind of the elderly patient with calcified valve leaflets.
Gotcha.
Yeah.
There's a image on here of what looks like a garden hose with a triangle hole on the top to kind of represent
Oh, yeah.
what it looks like
Yeah.
when you have basically no stenosis all the way to severe stenosis. And
Right. And so
Yeah,
that's kind
pumping
of
blood
that's
out of
sort
that
of
would not be
illustrating
good.
exactly what we've been talking about, like the
Yeah.
hose, like you're looking
pressure
at this
buildup
hose.
within the garden hose.
Yeah, and it's sort of that fixed space, right? It's
Mhm.
that fixed caliber of the blood's pushing through.
Yeah.
It's a kind of a good way to think about it.
Yeah.
You should
So I
post
have a
that.
question
That's a
for
good
you.
one.
You mentioned that she has AFib with RVR, not in this case, but
Yeah.
she had previously
Mhm.
had that. So are you worried about at all giving her medications that alter her blood pressure in this case? Since you said that it's hard really for the body to augment, or is that just really just during exercise?
So for things like, for example, she was on high dose metoprolol, right, which is hits the rate a little bit more than the blood pressure, and really slowing down the rate in somebody with aortic stenosis or anybody. If anything, it allows for longer filling times, so it actually sort of helps with forward flow,
Gotcha.
if that makes sense.
So really it's just exertional.
Exertional hypotension, venodilators that drop your preload.
Yeah.
Things that truly drop your metoprolol. If she was having rates in the 150s, 160s, and you gave her metope, and her blood pressure tolerated it, slowing the heart rate down actually would be a good thing.
Be a good thing for her.
Yeah.
Gotcha.
Wow.
If that makes sense.
Yeah.
This is a big one. Like I feel like it's really weird to me that I've never
Yeah.
heard about this
Yeah.
before.
Yeah, it is.
Very strange.
I keep racking up the deaths. I just keep thinking in my head.
I know, it's like, shoot. I wonder how many
Jeez.
people I shouldn't have done that.
Well, because before you had push dose nitro, we would just always give sublingual nitro,
Right.
and that's a lot of nitro,
It is a lot.
and you can't take it back.
No,
Like
You're
it's
stuck.
in there. Yeah.
can't take it back. Yeah.
Oh, wait,
that's the
here's
thing that's
a-
nice about BiPAP. You can turn it off.
Yes. Yeah, and that was just
Titrate
pre
it.
BiPAP.
Yeah.
That was all you really
Yeah.
had was Lasix and
It says 3 main causes, like we've already talked about. Calcium buildup on the valve for a variety of reasons. Rheumatic fever,
Yeah.
complication of
Yeah.
untreated strep throat,
Yeah.
can damage the
I
heart
don't
valves.
see that in the U.S. as much,
Yeah.
but internationally, that's probably, I would imagine, a very common cause.
Mm-hmm.
But we don't. I don't. Gosh, I can think of maybe a handful of patients since med school that I've seen with rheumatic heart disease.
How is that diagnosed?
Similarly, with murmurs and echoes.
Yeah.
But what I've been told is that the strep variants. Don't quote me. I mean, you can quote me on this, but so what I've been told by ID is the strep variants that we have in the U.S. are not as rheumatogenic as a lot of the strep variants in South America and places like that. And most people that get strep get treated with antibiotics here.
Yeah.
Yeah.
Right. And then lastly is congenital heart defects. Wow.
They talk about bicuspid aortic valve.
They do.
There you go.
Having a congenital heart defect such as the bicuspid aortic valve requires regular medical checkups. The valve condition may not cause any problems until adulthood. If the valve begins to narrow or leak, it may need to be repaired or replaced. Thank you, mayoclinic.org.
And there could be. I'm not a medical director for EMS, but it'd be interesting to talk to your guys' medical directors.
Yeah.
I'm curious what their take would be on this as
yeah.
the folks that are designing these protocols, right?
Mm-hmm.
And it does seem like the CHF patient is something that we see a lot.
We do.
And
Oh,
it's
yeah.
kind of like
It's very common.
the old CHF pneumonia.
Yeah.
What is it? And they kind of hammer that in during paramedic school and then throughout your career. You're always kind of revisiting those case reviews. But really, I don't.
We just marched
If it's
down the
been
algorithm.
mentioned, it hasn't been mentioned in this way that's
Yeah.
so applicable to just
And I
that
think,
easy physical exam.
Our patient population is getting older and older,
Mm-hmm.
and the amount of aortic valve replacements we're doing
Yeah.
it's a lot.
Mm-hmm.
So I think there are a lot of people walking around with this condition that we're probably seeing in the ER, seeing pre-hospital that it's good to be aware of.
Yeah,
you know.
absolutely.
Maybe not. Maybe the medical directors aren't seeing enough of it to say, "Hey, we need to change
Right.
our protocols."
Yeah.
Right. Which is fair.
Was the patient that we talked about, is she on any sort of a list for a valve replacement?
That I don't recall off the top of my head.
Yeah.
Yeah. I mean, her being on dialysis, she had a lot of medical comorbidities,
Yeah, so that's probably not helping her out.
but it's probably she may be on the list.
Yeah.
Yeah.
That was a good one.
That was a good
That was a
one.
really
yeah.
good one. I'm
Got
thinking
a lot
like
of things going through my head.
when anytime you drop off a patient, the first thing the doctor does is come in and listen to lungs and their heart. That's like number one,
Yeah.
right?
Yeah.
And it always seems just, I don't know, just like a functional way to start
Right.
your exam and you're talking to them at the same time, but it's really valuable. And
Yeah. I think most of the time, I think it is a functional. Hey, this is a part of my
Right.
costume. I've got this stethoscope on my neck. but there are one in I don't know, however, not many. But
Right.
there are occasional cases where you listen to their heart and it sort of changes what
you're like,
you're doing.
oh, okay.
Or you listen to their lung. And the other thing for you guys is differentiating heart failure and COPD is really tricky, I think.
Mm-hmm.
And a lot of people who have heart failure smoke and have COPD.
Yeah.
And there's a lot, the Occam's razor that you learn in, medicine of there's one problem and I need to fix the one problem.
Yeah.
When you're in actual clinical practice, there's a lot of people who have a COPD exacerbation and heart failure.
Yeah.
And
Like they did not read the protocols.
Right. They didn't read,
Yeah, dang it.
they didn't read the books, and differentiating what's the primary driver on that visit, it can be really hard.
Mm-hmm.
And again, pre-hospital, it's even harder because you guys are in a rig that's hard to hear things. You have limited time, so deciding which course to go down is sometimes you do both.
Mm-hmm.
Sometimes you say, hey, I'm going to give them some Lasix and I'm going to give them a breathing treatment
Right.
or whatever. And that's not necessarily wrong, right? I think this is just an interesting, unique case that
Yeah.
Yeah.
There's a lot of distracting things in
Yeah.
the case, like the dialysis and
Yeah.
the coughing and the smoking and
Yeah.
there's a lot of
Right.
distracting things.
I think if I had any other. I thought that one I just was like, oh, this is interesting, and this would have
It's a
been
perfect
really
EMS
easy to
case.
fuck
Yeah.
this. It would have been easy
Yeah.
to fuck this up.
Oh.
Yeah.
Yeah.
And I've seen it get messed up in residency, where I have seen a patient code from nitro
Yeah.
with aortic stenosis,
Mhm.
and it is when you see it once,
It sticks with you.
you're like, oh man, gotta be aware of that.
Yeah.
Yeah.
Awesome. Well, Doc, thanks so much for coming. We always enjoy having you.
Thanks for having me.
Definitely appreciate the
Yeah.
case review. This
I learned
was
some good stuff.
This is a career-altering one for me. It's just going to be one of those other things I have in the back of my head of,
Mm-hmm.
oh,
Everyone's
we
gonna
should
be
probably
like,
try
why does
this.
Steve always listen to heart sounds?
Yeah, I know. And then I'm going to be the guy that, okay, Steve's
No,
got to
here
listen
we
to his
go.
heart tones. You know?
Nerd.
Yeah. Okay. Yeah. 5-star. Here we go.
They hurt their legs, Steve. Why are you
Yeah.
listening to their heart?
Exactly. Yeah. He said he has aortic stenosis. This is a trauma call. Yeah, I know. Well, cool. We'll leave it there, and we'll catch you guys on the next one.
All right.